critical care of the neurosurgical patient. In this lecture, I'm going to talk about the post-operative care for a neurological patients. Patients who have undergone a surgery in the neurosurgical department. In this lecture, I'm going to talk about general lines and not specific surgeries, although it is required from you to know each surgery and its prerequisite and post-operative care that is associated with it. Also, I'm not going to talk about the general principles of the post-operative care because this should be discussed in separate lectures. I am only going to focus on the broad line of the post-operative neurological patient and the possible complications that might happen and how could we face these situations. Now, which patients should be admitted to the intensive care unit after a neurosurgery? Supra and infratentorial craniotomy for tumors or aneurysm. Patients who have done craniofacial and transsphenoidal surgeries, major spinal surgeries, or patients who have done carotid artery surgeries. Endovascular procedure including embolization of arteriovenous malformation and aneurysm. Patient with significant medical comorbidities, elderly, or with difficult intraoperative course. The key management of neurological patient in the ICU is early detection and treatment of post-operative complications, example, seizures, stroke, bleeding, hemorrhage, preventing second insults, and emergence and recovery from anesthesia, assessment of impaired consciousness, because this can be a very important sign for the occurrence of complications, restoring and maintaining normal body temperature, because usually this is a long operation time and there is a lot of fluid transfusions, so the patient usually suffer from hypothermia, pain management, and post-operative nausea and vomiting treatment and prevention. And of course, prophylaxis from DVT and GIT bleeding. Now, what is our protocol? Our protocol aims usually for neuroprotection. What is neuroprotection and how can we do that? Neuroprotection is the golden goal for management of intra and post-operative neurosurgical operation. All neuroprotection measures are directed either to decrease the cerebral metabolic requirement or to improve cerebral oxygen and nutrient supply. How can we do that? By improving oxygen supply. How? By maintaining the hemoglobin level, the oxygenation and cerebral blood flow. Prevent hypoglycemia or hyperglycemia, as both are very harmful to the brain. Decrease cerebral metabolic rate. How can we do that? Examples of our management: drugs as barbiturate, vasodilators, corticosteroid, magnesium, erythropoietin, cyclosporin, and progesterone. These are some drugs that can be used to elicit a neuroprotection protocol. What about the post-operative complications? There is two types of post-operative complications that can happen to a neurological post-surgery patient. Systemic complication and neurosurgical complication. The systemic complication is coagulation disorders, thromboembolic problems, pulmonary or hypovolemia, infection, metabolic problems, air embolism, and pressure sores due to prolonged immobilization. This is like the general complication that can happen to any major surgeries. While the neurological complication is a little bit specific, it is directed to the patient who have undergone a neurosurgery and could be post-operative hematoma, whatever the site is, cerebral ischemia, brain swelling, infection, seizure, hydrocephalus, or CSF leak, or cerebral herniation, or cranial nerve lesions. Now we are going to talk about the emergency management of such complications and how can we detect it. Elevation in the intracranial pressure and evolving herniation are critical to detect early and should be treated as early as possible. Both represent the most life-threatening complication of neurosurgical procedures. Signs of elevated intracranial hypertension can be seen as a result of evolving cerebral edema and ischemic stroke and intracranial hemorrhage. Signs can include headache, nausea and vomiting, loss of spontaneous venous pulsation on fundoscopy. And fundoscopy is one of the simple and important tools to detect such a problem. Serial examination is the best method to detect and diagnose post-operative complication and should be performed every 15 to 30 minutes immediately upon recovery from anesthesia for the first 1 to 2 hours, and then every hour for the next 6 hours. Alternatively, a complication that can produce reduced level of consciousness and focal exam changes include seizure, ischemia, tension, pneumocephalus, and CSF leak. And we are going to discuss these complications in a little bit of details. Post-operative cerebral edema or intracranial hemorrhage should be suspected with the development of new neurological deficit, cranial nerve abnormalities, decreased level of consciousness and seizures. In case of suspected cerebral edema or intracranial hemorrhage, emergent CT imaging and notification of the neurosurgeon is very important. Surgical intervention and treatment, including external ventricular drain placement, hematoma evacuation, and decompressive hemicraniotomy, is often necessary for monitoring and prevention of secondary neurological injuries as a result of intracranial hypertension, herniation syndromes, and brainstem decompression. Rapid expansion of the hematoma frequently require evacuation. Emergency medical treatment of intracranial hypertension and cerebral edema can include patient positioning, intubation, and brief hyperventilation, osmotherapy, sedation, and induced coma for suppression of cortical electrical activity. As first line of medical therapy, the patient head should be elevated at least 30 degrees to facilitate venous outflow from the brain. Any external compression on the neck, example neck collar, should be removed if it is possible to do so. If the patient has natural airway, i.e. he is not intubated, the patient should be intubated and sedated. Cerebral edema often worsened by elevation of carbon dioxide levels, which can be managed with invasive mechanical ventilation. Brief periods, less than 2 or 3 hours of hyperventilation below a normal departure pressure of carbon dioxide can be induced to elevate the intracranial hypertension. While on the other side, prolonged periods of hyperventilation result in development of cerebral ischemia due to arterial vasoconstriction. Sedation is recommended in these cases. Various hypnotics can reduce the metabolic requirement of the brain and thereby reduce cerebral blood volume. Osmotherapy in the form of intravenous mannitol or hypertonic saline is often necessary. In case of cerebral edema, cortisone as dexamethasone or methylprednisolone may also be given. However, the effect of cortisone is often minimal and they should not be administered alone in case of severe cerebral edema. Intracranial hemorrhage. It occurred in 1 to 3% of the neurosurgical patients, is associated with perioperative hypertension, coagulopathy, thrombocytopenia, high-grade vascular tumors, and emergent surgeries. Also, it can occur in AVMS and after subdural hematoma resection. Most cases of intracranial hemorrhage occur within 6 hours of surgeries. More than half of post-operative hematomas are intraparenchymal or epidural. Surgical intervention must be considered. Now this is the picture of the intracranial hemorrhage showing the whitish change in the image as we can see on the left side, while the diagram on the right show the site of hemorrhage as we can see. Now, types of intracranial hemorrhage is illustrated in these diagrams. As we can see, there is the subdural hematoma, and there is the epidural hematoma, and the intraventricular hemorrhage, and the intraparenchymal hemorrhage, and this diagram is very illustrative. Also, the intraventricular hemorrhage is present on the right side as we can see. Cerebral edema is often responsible for transient deficit and occur as a result of tissue manipulation. Cerebral edema should be expected in patients with glioblastoma, repeated procedure, and prolonged operative time. Treatment include corticosteroid or osmotherapy. And this is the image of the severe cerebral edema, as we can see, and we can see the compression that this edema has on the brain tissue and the ventricles, as we can see. CSF leaks occur in 2 to 5% of the transsphenoidal surgeries. Risk factor includes preoperative radiation treatment, repeat procedure, large tumor size, and advanced age. Predispose the patient to meningitis and intracranial hypotension. Treatment of the CSF leak include post-operative supportive care and surgical repair of the leak. If meningitis or ventriculitis is suspected as a result of a CSF leak, early treatment and hemodynamic support with broad-spectrum antibiotics should be started. Fluids are indicated, and CSF culture, if possible, should be done. Now, what about stroke? It occurs in 2 to 3% of the patient undergoing carotid endarterectomy and 4 to 8% of those undergoing an endovascular procedure, including aneurysm, coiling, and carotid angioplasty and stent. May be the result of cardiogenic or thromboembolism, distal embolism of foreign material, systemic hypotension in the setting of vascular stenosis or occlusion. Vascular occlusion may also result from cerebral edema if brain herniation develops. In the post-operative patient, ischemic stroke is often treated conventionally with permissive hypertension and low-dose aspirin without the anticoagulant or the fibrinolytics. Induced hypertension is not a first-line therapy and is not routinely recommended. In rare circumstances, intra-arterial thrombolysis or clot extraction may be possible if the risk of post-operative bleeding is minimal. Now, this image shows the difference between an ischemic attack on the left side and a hemorrhage on the right side. The difference is quite apparent between both images. Pneumocephalus. Pneumocephalus is a frequent and often benign post-operative complication. Small amount of intracranial air are well tolerated and typically only manifest with headache. While on the other hand, tension pneumocephalus is a neurological emergency that requires immediate treatment with needle or burr hole decompression. Now, this is the image of the pneumocephalus, and when air is trapped in the bilateral front lobe with air trapped along the falx meninges, the appearance on the head CT is called Mountain Fuji radiological sign. Seizures occur as a result of cortical irritation from supratentorial operations. They are often associated with high-grade astrocytomas, AV malformations, metastatic tumor, abscess, and midline meningiomas. In the NICU, any seizure activity should be considered evident of post-operative complication such as stroke or hemorrhage until proven otherwise by brain imaging. Seizure prophylactic with anti-epileptic drug should be started for these patients. Most complications that neurological patients experience are related to pain, nausea, vomiting, and shivering. Pain should be expected in up to 80% of the patient, while post-operative nausea, vomiting occur in approximately 50% and shivering in 30%. Euthermia and prevention of post-operative shivering is very important. Why? Because the goal is hypo or hyperthermia can significantly affect the comfort of the patient, hemodynamic, and the oxygen consumption. Shivering due to hypothermia occurs in 40% of the post-operative patients and is associated with 200 to 400 increase in systemic oxygen consumption. Now, treatment focus on warming of the patient to its normal body temperature. How can we do that? By warm blankets, forced air warm devices usually are enough to restore the body temperature. If shivering persists, medication can be considered. Such medication may be mepridine or low-dose propofol if the patient is intubated. Post-operative neurological pain should be treated because it is associated with a significant increase in this sympathetic tone, hypertension, and systemic oxygen consumption. Post-operative pain therapy can include oral and intravenous analgesic alone or in combination. Also, we can use patient control system, which can be used in a dose-limited pumps, is highly effective, only if the patient is awake. Drugs that can be used like acetaminophen, fentanyl, morphine, hydromorphines, and oral agent include oxycodones and so on. Post-operative nausea and vomiting is a frequent complication that is particularly prominent in posterior fossa surgeries. Projectile vomiting can be an indicator for hydrocephalus or intracranial hemorrhage. Post-operative nausea vomiting is associated with an increased risk of aspiration, hypertension, and elevated intracranial pressure. Now, how can we treat? Drugs, of course, ondansetron, promethazine, dropridol, corticosteroids. Now, what about the gastrointestinal bleeding and the venous thromboembolism prophylaxis? Well, neurosurgical patients are at increased risk of deep vein thrombosis and subsequent pulmonary embolism. Why? Because of the prolonged time of recumbency. Mechanical DVT prophylaxis coupled with chemoprophylaxis with low molecular weight heparin or unfractionated heparin is effective for reducing the risk of DVT. Neurosurgical patients are also at increased risk of gastrointestinal bleeding from mucosal ischemia, which can cause to stress ulcer. Stress ulcer prophylaxis include antihistamine receptor blocker or proton pump inhibitor. These are the drugs used for GIT bleeding: H2 receptor blocker or proton pump inhibitor; for DVT, sequential compression, low molecular weight heparin, or unfractionated heparin. Hypertension is often transient Post-operative hypertension is frequently treated with sympatholytic agent, especially beta blockers. Short-acting intravenous agent, continuous infusion are preferred as the first line of therapy. Drugs, example labetalol or nicardipine or hydralazine. Post-operative care and monitoring. Careful post-operative neurological monitoring is indicated in all neurological patients for a minimum of 6 hours after surgeries. In general, post-operative patient will require only 12 to 24 hours of ICU level monitoring and can then be discharged to the general floor. However, when complication occurs, the time to detect and intervene on the problem will directly affect the recovery. Now, what is our tool in monitoring? Of course, the simplest is the Glasgow Coma scale, pupil abnormalities, pressure on the midbrain, cranial nerve monitoring, example, eye exposure, swallowing abnormalities, systemic monitoring as cardiopulmonary, respiratory state and temperature, biochemical parameters as hematocrit, electrolyte, osmolarity and blood glucose level. What about brain monitoring? Intracranial pressure and transcranial Doppler is very important, cerebral oximetry and jugular bulb oximetry. Non-invasive cerebral oximetry will be shown to you in later slide. Continuous EEG, magnetic resonant spectroscopy. Now, the way of measuring intracranial pressure is demonstrated in this diagram. There is different types and sites to measure the intracranial pressure, and according to the need, the type will be chosen. While transcranial Doppler is a much easier and non-invasive method. Non-invasive cerebral oximetry is also non-invasive method and can give us a good idea about cerebral oxygenation. And thank you for your time.